Welcome and thank you for joining us. I'm John Copps and I'm Managing Consultant at Mutual Ventures. Very much looking forward to this conversation, and we've got a great range of speakers. So looking forward to a lively discussion. While everyone joins, I just want to take a moment to say that this is one of a series of speakers that you are joining from Mutual Ventures focused on current topics in public services. Next week, we have one focusing on levelling up and how you can make the most of the government's levelling up agenda. And in March, we have one on provider collaborations in health and social care. You can visit our website to find more and learn more about our work. So integration is a really important theme across public services. In very simple terms, it means to work together, that is, across organisational and team boundaries. Words like seamless, multi-agency, breaking down barriers will be familiar to you all. The potential benefits of this are better services for a lower cost and better outcomes. But the real question is how we do it in practice. After years of edging forward on this agenda, the experience of the pandemic has made integration a real imperative. Children's services like yours have worked hard to adapt to respond to the crisis together. There's been great examples of working together, including in West Sussex, in Stockport and in Cornwall, where we'll hear examples today. But perhaps the hardest time is still to come as hidden harms begin to reveal themselves. We see a spike in social care cases and new inequalities emerge. In the health service, NHS England's latest proposals for integration and in health and social care bring a welcome emphasis on place. They acknowledge that health starts in the community and integrated care is only meaningful if it sees health and social care as a single system, including local government and the voluntary sector. So, some of our key questions today. What are the challenges that integration can help us solve? Where are the opportunities, and what real-life examples can we learn from? They're my questions, but you'll have your own. And please use the Q&A function on our webinar here to let us know what they are. Please leave your name as well if you wish, and we'll try and get to them as many as possible at the end. So, introducing our speakers. First of all, we have Jack Cordery. Jack is recently has been the service director at Cornwall County Council, and he has 38 years experience of being a social worker. And Jack, 38 years to come as well.
Very funny.
And we also have Deborah Woodcock, who is at Stockport Council and is lead on the Stockport Family Programme and senior principal social worker as well. Hello, Deborah. And hello, Deborah. And Maura Appleby, who is a health visitor by background and works for NHS Foundation Trust in Stockport and is the lead for Stockport Family. Hello, Maura.
Hello, good to be here.
And finally, we have Aaron Gain, who is senior programme lead for commissioning, working for the joint commissioning team in West Sussex. So Aaron also has a PhD in organisational models, so brings a lot in terms of integration here. Hello, Aaron. Well, look forward to talking to all of you. First of all, I just want to say thank you for joining us, and we'll go first over to Jack, who is going to say a little bit about some of the challenges and opportunities.
Thank you, John. Well, good morning, colleagues, and thank you for joining this webinar. I am absolutely delighted to be part of what surely has to be one of the most important professional discussions around, and that is the need to strengthen our effective partnerships, which have been amplified. The need for it has been amplified by this dreadful pandemic and the impact of the lockdowns on the health, social and economic well-being of children and young people, which looks like that it's going to be here for the long term. I'm guessing that I can safely assume, that everyone who has joined this webinar believes that integration is a good thing. That is, it is the way to go. That is, it is the key to improving the effectiveness of health and care services to children and families. Simon Stevens, he's responsible for £120 billion worth of health and care services, certainly believes it is a good thing. His NHS long-term plan talks about, quote, genuinely integrated teams of GPs, community health and social care staff. He also talks about greater collaboration between health and care systems. And he talks as if collaboration and integration are the same thing, being the way to, quote, accelerate progress in meeting our most critical health and care challenges, and there's certainly plenty of them. He also talks about how the development of integrated care systems have allowed organisations to work together and to coordinate services more closely, to make real improvements to people's lives. And he concludes, our challenge now is to spread the experience of the earliest integrated care systems to every part of England. The government clearly believes integration is a good thing. It has not only integrated NHS England and NHS Improvement, it has integrated health and care into a single government department. But more than this, it is now exploring how to embed integration into legislation and guidance. So that's all good then. This discussion isn't new though, is it? For those of us who have been around long enough to remember the early days of implementing the 1999 Health Act, that's 22 years ago, we will recall similar language and exhortations, as well as the provisions of sections 26 to 32 of the Act, aimed at strengthening partnerships, greater cooperation and collaboration, along with flexibilities to make it happen, like joint financial arrangements. So one question has got to be, hasn't it? If we do believe it is a good thing, and we keep going on about it, writing it into our big policies, our strategies and plans for over 20 years, then why have we made so little progress? That may be harsh, but setting aside the many working and effective exceptions, at scale, are we just as fragmented, segregated and disintegrated, if those are the anonyms to integration, as ever we were? What do you see and what have you experienced as the barriers to integration, to greater collaboration, to more coordination? I'm going to share with you some of the barriers I have faced over the years and some of the issues I believe you have to consider if you're going to make integration happen, if you're going to make integration successful, two really different things, and if you want the successful integration you've put in place to last, to outlast you. So one of the barriers I've faced is a cognitive or confirmation bias about the benefits of integration, whatever it means to the different people involved. A strong belief that it does and will improve things for children and families in any and all aspects of need and risks. Such an evangelical, uncritical approach can lead to abject failure, strenuous rowing back, and skepticism from your workforce. And the damage that that can have can be long-lasting. Looking at research on integration does help to develop respectful skepticism. So a quote which I think epitomizes a lot of the outcomes: evidence on the outcomes of integrated working is complex and contradictory. One piece of research goes on, it can be hypothesized from the research that outcomes are specific to the situation and that a general theory or approach cannot be developed. I'm not sure that Simon Stevens has looked at that research. A second barrier: do we even agree what we actually mean when we talk about integration? Generally, let alone when it comes to children's services. Do we mean vertical integration, for example, creating a seamless experience for children and families under an integrated accountability structure, from universal services through early help to acute and complex interventions? Or do we mean horizontal integration, bringing services or professionals together from different agencies to provide a more holistic response to the needs of children and families under integrated management, integrated decision-making? Is it conceptual or is it practical? Practical for the people who receive the services. Do we see integration as an absolute or as a continuum, from cooperation, like information sharing or aligned commissioning, to collaboration, like joint planning or joint commissioning, to coordination, like shared goals and joint management, or to merger under a single management and single budgets? The third barrier that I'd like to talk about that I've experienced is there's confusion about what integration looks like, how it works beyond the conceptual, in the real world of operations for staff and for the people that use our services. For example, there are mixed views about whether multi-agency teams, or better, multidisciplinary teams, represent integration. Apart from the well-worn analogy of soup or salad, primary research and research reviews by bodies like Sky and NICE suggest that multidisciplinary teams are not of themselves integration, but they can support integration by overcoming some of the barriers. Bridging professional boundaries, breaking down the barriers of competing cultural and organisation differences, reducing professional snobbery and rivalry, we all know that exists, reducing time-consuming bureaucratic processes and getting all the right help to the right people in a timely way. So the objective of that is multidisciplinary teams is creating services that are comprehensive, holistic, continuous and seamless, as John was talking about earlier. The research suggests that MDTs are most effective for people with complex needs, those who benefit from getting all the help they need in one go, like older people, children, and people with mental health problems. This sort of research provides a steer in terms of deciding where, if, and what kind of integration can improve the effectiveness of your services. And then there are all the small things, which I'm sure you have all experienced. Vested interests of senior leaders, organizations, and professionals, different legal duties, different values, visions, and aims, different financial arrangements, disconnected processes and systems. No one stays in one place long enough to see integration through, and it's all just too difficult. But there aren't just barriers, there are also enablers and encouragement, and I want to talk a little bit about those. A big encouragement for those working in children's services has got to be working together. Working together is an example of conceptual integration, and the concept being safeguarding children is everybody's business. But it's turned into a legal duty on agencies and professionals to collaborate and coordinate their individual and collective responsibility to safeguard the welfare of children through statutory guidance on an integrated approach to practice, processes, and systems. And if you doubt the benefits of integration, working together has contributed in a major way to making the United Kingdom one of the most effective nations in the way that it safeguards its children. So one of the enablers I have found is John Davis's book on integrated children's services. That's Sage as the publishers in 2011, helping in defining what we mean by it, where we are going on the continuum, particularly for the all-important task of communicating and engaging with all our stakeholders to develop a shared understanding and vision of what we actually mean by it. Davis is a senior lecturer at Edinburgh University who has undertaken extensive research on integration in children's services. He also provides some very useful case studies to illuminate his research findings. Another enabler I have found is the Children's Workforce Development Council paper, Integrated Working Explained, 2008. It's helpful. It's particularly their simple but powerful description, and I quote, "Integrated working is when everyone supporting children and young people work together effectively to put the child at the centre, meet their needs, and improve their lives. As I say, simple and powerful, but the paper goes on to itemise the features of a more integrated approach to helping children and families. Shared goals, a common approach, such as the assessment of needs, effective information sharing, a lead professional for the family and the child to relate to, multidisciplinary teams around the child and the family to meet all their needs in one go, a common core of knowledge and skills supplemented with specialisms, integrated processes and systems, integrated leadership and management decision making. So in summary, in my experience, my advice to you, for what it's worth, check whether your existing partnerships are change ready and what needs to happen for greater integration to be successful. Be clear yourself and with your partners about what you mean by integration and what the objectives are. Find a simple and powerful way to communicate your concept. Develop a detailed analysis of the barriers, but also, as I've talked a little bit about, the enablers. Listen to people who use the services. They will have a pretty good idea if integration and what kind of integration will improve the services. The same with your practitioners and clinicians. Listen to them. Review the research evidence. Be confident that you are looking to improve, what you are looking to improve will benefit from integration. Set success measures, the intended outcomes, and be flexible. Get the fundamentals in place first, like your ICT, for example, and take a staged approach over a realistic timescale. I'm going to finish very briefly with a story. Bedford University, Donald Forrester and colleagues undertook an evaluation of a rather well-known model of children's social care and found that the staff were happier operating under an integrated model of practice within multidisciplinary teams. And we all know one thing for sure: we are all more creative, productive, effective, and resilient when we are happier. In a recent conversation with the chief executive of a national service, she told me that she had designated one of her directors as the director of happiness, for real. Thank you. I look forward to your questions.
Thank you, Jack. They're really thoughtful reflections there on the topic. And just before we move on to the practical examples from Deborah, Maura and Aaron, just a quick question from me. So you talked a bit about our tendency not to be very critical of integration and whether it's a good thing. So just to sort of picking up on that, do you think there are general benefits of integration? Or do you think the logic is that we need to look at integration on a case-by-case basis?
I think there are definitely general benefits, but the way that you understand it and the way that you apply it has to be very situational. And that's not just me talking from my experience, which I think is research experience over the 37 years you talked about, but it's very much one of the conclusions of research as well. You've got to really think about what you mean by it, but what you mean by it in a particular situation.
Excellent. And we'll come back to some of those questions. So now if I could invite Deborah and Maura to pick up and talk through your example. Thank you.
Thank you, John, and thank you, Jack. That truly was an excellent start to this exciting webinar. So thank you very much. We're delighted to be here, Maura and myself. We're just going to introduce ourselves. First, I'm Deborah Woodcock. I work in Stockport. I'm the Director of Operations for Stockport Family. I'm also, as John said, I'm the social worker by background, and I'm Stockport's Principal Social Worker. Today, our presentation is very much a case study. It's not a theoretical run through of any of the themes that we've heard from Jack, but actually I hope we'll see some of the threads through in terms of both barriers, but also and importantly some of the encouragers and enablers referenced. I'm going to hand over to Maura first, and then I will come in later on in the presentation. It's lovely to see you all. Well, I'm not see you, virtually see you all, and there's some really great friends in the audience, and I'm delighted to see those people there.
Hello, thank you, Deborah and Jack, for getting us started. My name's Maura Appleby, and as in the introduction, John said, I'm a health visitor and a nurse by background, and I've worked in Stockport for many years now, and been part of an integration journey, which actually probably started in the days of, when I think back, working in a Sure Start local programme and seeing the benefits of integration at that point in my career. And interestingly, our director of Children's Services and Education currently had a background of working in a Sure Start local programme and saw the same benefits, and probably that's guided her journey since then as well. So yes, I worked in parenting teams and in frontline health visiting role within that local programme, and brought some of that experience to the table really when we started our integration. So we'll just have a look at our journey so far to begin with, and think about why we started the journey first. Next, please. We were challenged and are always challenged by this question: how can we work together to achieve the best for our children and families? And it's the most simple question and fundamental question to our common purpose within Stockport Family. And it is a question which at key moments, people like Deborah will ask me if I'm struggling with a decision, or if we're struggling with our transformation, we come back to this basic question. And it then revolves around what we can do to improve outcomes. Next slide. This desire to improve outcomes is what drove our initial phase of integration. And if we start the journey on our next slide, the beginning of our journey was when we formed our integrated children's service, which was at a time, I think what Jack referred to in terms of unique context for integration is really important here. And our recipe for integration will not necessarily suit everybody, but hopefully they'll be learning from that. We were in a position probably around 2013-14, where we'd been implementing, if people remember, a call to action at that time under David Cameron's government for more health visitors. And so we'd had investment in health visiting services, and we were coming out of the investment phase of children's centres, and there was a need to balance the books really in local councils around children's centre investment. Commissioning for health visiting had changed, and we were potentially going to have a bit of a paradox where this investment had gone into health visiting, but then the public health grant changes and potential reductions there were going to mean we might, after putting all that effort in, then actually have to lose investment in that service. So we had a financial imperative to think differently, and we also recognised that despite the fact that we'd had investment in children's centres in early years and in health visiting, we still couldn't hand on heart say we were getting the outcomes that we really wanted, and that we were working effectively to common purpose and shared objectives across those early years services. So that recognition, I think practitioners recognise that, which always helps with implementing change. And obviously our leaders recognise that we could do more. At the beginning of our journey, we were recognising we would maybe aim to do more with less. So our leaders kind of really had a strong vision, and despite the difficulties and the barriers, some of which Jack's referred to, we pursued that vision and that ideal, really. And it did touch a nerve a little bit, Jack, when you said an evangelical approach, because we do not want to necessarily be in that camp. But once we got the belief, we were quite keen on pursuing it. So we approached the development through a lot of kind of work in locked rooms, looking at a matrix management approach that might work across localities. Instead of taking investment out of health visiting, we probably asked more of our health visiting leaders across the early years, and they took much more of a senior leadership role in locality working and in early help, and a much more broader vision of the way our service worked. And the whole development was really underpinned by culture change as well, in terms of how we approach that. And we'll come on to that a little bit more when we talk about restorative practice, but recognising and respecting professional difference, with the cliche that we've got there about soup, not salad. But it's been really important to have a cultural model of working that's been very respectful and really enabling. So we've learned so much along the journey, and the importance of relationships underpins our work, the way we support our managers and teams. And quite often I say we've asked a lot of our middle managers, probably our people, we've asked a lot of them, but they have had a belief and they've seen the benefits of the change, so have stayed with us, and we've got a really stable leadership team as a result of that. So our first phase included those services mentioned there. There was a big focus on early years and on early help, and then at next slide we moved on to potentially the bigger prize, which was really working much more closely with children's social care. If you could, next slide please. And that was when all our social work teams became part of our integration in localities. And that's really shown us even more benefits. I think we've lost the slides here, have we? It's shown us much more benefits in terms of the case study that we're discussing today. And the complexity of our system that's been a barrier to improving outcomes for families. So moving into an integration with children's social care really then drove us to better communication and information sharing. For example, health visitors and social workers being able to access early help systems, IT, from an IT point of view, being able to really focus on what we're doing at an early help level, and recognising the importance of the relationship with a practitioner and supporting somebody to work at that level rather than referrals, a pattern of referrals. We wanted to reduce handoffs and transitions, and we wanted to reduce referrals into children's social care that didn't result in that we'd have an initial assessment, but it would not carry on with a longer term piece of work, because in those cases we were thinking maybe the initial assessment wasn't necessary and we needed to look at that. So our integrated planning of services, and we've definitely seen our outcomes in terms of effective use of resources have been evidenced, and more recently, as our integration has progressed, we've taken this forward with what works in terms of the evaluation of social workers in schools, and this is part of our next stage of development as well. Okay, next slide, please. And I will hand over to Deborah, I think, at this point.
I'm just wondering what's happened with the slides. The next slide was the honeycomb one, Lily. That's right. Okay, there we are. Thank you. That's just to illustrate. Thank you very much, Maura. Just to illustrate the scope of the model that we're currently working with, and you'll see embedded there within that honeycomb the integration and involvement of services right across the system, those which are both universal and targeted within the children's services in Stockport. And you'll see I mentioned who are we now, who are we at the moment, because Maura's talked about phase 1 and phase 2 of the integration journey, and we're embarking currently on phase 3, which is a much closer integration with those services and teams around schools, and integration with our school communities as well, which is going to be key to our phase 3 programme. Next, please. We were really clear as we embarked on this journey, this discovery, over really now probably about 10 years, I think, Maura, that no service delivering to children does this in a vacuum, and the outcomes for children will only improve if there's an alignment between the actions of family and community and all those agencies that touch the lives of children and their parents. And the core skill of the children's workforce and their leaders was to provide the most effective catalyst for system change. Next, please. We saw some of the evidence and research that Jack referred to, and thought about that in terms of what we wanted to achieve. We recognize
Deborah, you've inadvertently hit your volume button. So
I leant on it. Apologies. Can you hear me now, colleagues?
we can hear you.
Apologies. I don't know when I went quiet. I'll just start that sentence again, shall I? We looked at some of the evidence and research that Jack has referred to, and we thought about what we wanted for the change programme in Stockport. We recognise that sustainable change in complex systems can only be achieved if sufficient attention is given to 3 components: the structures, the agreed pathways and conversations between those structures, and behaviours. And we wanted to give attention to all elements of those 3 key components. We wanted to give real attention to all elements of that. We attended to these. We've put them down as five jigsaw pieces in our jigsaw motive. Working in collaboration, designed by doing. That was a very important part of our programme. I love the end of Jack's presentation talking about a happy workforce. Really important to us is that we attended to the engagement and involvement of our workforce, and wanted to empower and enable the workforce to feel that they were part of the design of our programme. And we spent quite a lot of time working with the workforce and the leaders to embed a culture. We call it design by doing. You can call it everyone's a social scientist. You can call it whatever you want, but essentially what we wanted to do is recognizing that change from the bottom was as important as change from the top. And within that integrated workforce, within the wisdom that was part of this breadth of experience and knowledge and skills, there were great ideas happening every day, and we wanted more of what happened and worked to be part of our programme. So we developed a slogan of design by doing, and people were encouraged and enabled to try things out and give them a go, and fail fast and then move on to the next thing. We redesigned lots of roles within our system. We had the matrix management approach that Maura and Jack have spoken of, and we also looked both horizontally and vertically at the way in which we were leading across and within the system. The data we've spoken about, and that's been absolutely critical in terms of making sure that we had shared data sets, but also a shared case management system, or case management systems that were accessible at all stages through the system. And then the other element which we've seen as being very, very important is that place-based locality, linking people to their assets in their communities, and in particular, you've heard me mention that focus on schools. We probably ought to move on because we're taking up too much time now. Next. So those are some of those key elements of our programme. I'll just mention a couple more as we go through. We've seen these as sort of creating the right conditions rather than rules for systems for best practice to flourish. And you know, in terms of outcomes, we've had some really good external scrutiny of elements within our programme, CCG, CQC, Ofsted, etc. Next, please. So locality focus with emphasis on community resources and universal provision within those communities. So that integrated approach within the community, both with the community and in the community, with an idea that the locality workforce could call in and draw on some of the expertise that could only be held at a sort of specialist or borough-wide level. And importantly, as we redesigned and redefined the way in which we delivered our services, we wanted to take a whole child journey approach to work with families. We wanted to avoid and reduce the number of handoffs and transition points, which are very often functionally created for an organisation as opposed to a family. So we took a whole child journey approach, in particular with our social workforce, to work with families. Next, please. We can move on to the next slide. Maura's mentioned, and there's been reference to culture. We wanted very much to embed a clear and strong value base within our model, and have chosen over the last 6-7 years to embed restorative practice as our practice model, and that has enabled us to have a very clear way in which we work with each other and we work with families. It's a model that had been used within schools in Stockport, and we were very encouraged to hear about the impact that was having on families. And critically, I think, particularly for this integration piece, is that sense of a both shared purpose but shared language, and when we've got the difference of languages across health and local authority, that shared language of working with families has been really, really important to our journey. Next. Next. And we'll move on to the next slide, please, because those are a couple of 4 examples of some of the ways in which we've embedded our integrated working. I think perhaps we'll touch on those in questions if they come up, and we'll move on. Lots of learning. We've had enormous amount of learning from this process, and we continue to learn. We see ourselves very much as a learning organisation. We're certainly not in our finished state of integration. I don't know when that will come, actually, and as we hear new ideas and new emphasis from central government around integration, that gives us new challenges and new opportunities, particularly in the space around commissioning, and new conversations being had every day. Next. Lots of next steps. I've heard me mention phase 3 and opportunities for us to work both in a local and particularly within the Greater Manchester context. We've not mentioned COVID, but obviously the opportunities that that the integration model has given us has meant we've fared reasonably well, been very agile and flexible during the pandemic, and able to mobilise alternative pathways into support and care right from universal through to targeted in a very, very flexible way. So we feel that it's served us very well during the pandemic. I'm going to stop there because we've overrun our time. I'm conscious of the next presentation.
Thank you, Deborah. Maura, a great example there, and there's been some really good questions coming through, which we'll get to. If I could just pass over then to Aaron and for your piece. Thank you.
Yep, thanks, John. Thanks, everybody. Sometimes it's really good to actually be third in the line, because I realise I've had the chance to listen to everybody's presentation, which I hadn't done before, and so I've learned some things myself. But also, I think I've learned that what I'm going to talk about is different, but is in the same line of thought that my colleagues have as well. It adds a bit of difference, but it's not in contradiction. So some of the things I'm going to say are really good examples, I think, of what Jack was saying right at the beginning around, well, integration is a very bottom-up thing at times, and the lessons that we learn can be done by the case studies of actual existing bits of integration. So it's really, really helpful for me as well. So what I'm going to just talk you through is an experience of the mental health support teams and schools in West Sussex. I'm going to it's not a talk about mental health support teams and schools as a sort of policy. It's not an evaluation of it. It's about looking at this particular aspect of work from the prism of integration and what does it tell us about integration, not about the bits and ins and outs of that particular policy. So I'm more than happy to talk to colleagues if they want to talk about that. So I'm just going to talk about three things really. One was just a little bit of context. Then I'm going to just explain briefly mental health support teams, schools, but I'm not going to go into lots of detail, just give everybody a bit more local context and policy context. And then I want to just go on to the last two slides, which are about the integration lessons. So about context, Jack and colleagues have spoken about these already, and I just wanted to highlight a couple of things really. Obviously, there's always been a history of struggles around integration. It's one of those things which is sort of easy to say, but hard to do. And it's hard for lots of reasons, which are historical, embedded, they're about professional training, they're about, you know, the nature in which we do our work, which involves quite important, quite narrow professional judgments on things, and it's quite difficult to do. So it's like a constant thing going on, and we do need to be wary of those sort of words that are used indiscriminately, like cooperation, collaboration, without any real discussion. And there's just a couple of things I wanted to talk about, sort of research, is that a lot of early research did talk about, and a lot of grey literature talks about leadership overcoming complexity. So the idea that if you just get the right leader in a certain place at a certain time, that they can overcome all the difficulties that you have here and all the barriers. And most of the recent research doesn't seem to suggest that's a very good way of doing things, that there's an absence of why questions. You do need to talk a little bit about the why, the conceptual stuff that Jack's talked about. It's not just sort of irrelevant academic talk. It's a really good reflection as a group of professionals to think about why you're doing something, and also being quite honest about the professional differences that people have about identifying need, and having that in an open way rather than a conflicting way. You can do it, but it is hard work, and I think that's the thing I keep reflecting on, is the hard work nature of this. And just the last point was that this integration agenda is coming and coming, and it's going to get bigger and bigger as we go through into post-pandemic sort of situations, waiting lists, etc., etc. It's coming. There's lots of new policy and lots of local need for it. So we've got to sort of get our heads around it. So next slide. I just say what MST teams were. So mental health support teams in schools, they're a strand of the Green Paper. They're about additional funding coming from the NHS sort of Department of Health and Social Care, that's about increasing the number of schools that we can support the well-being of children and involve the education of children's well-being practitioners. So we get additional staff, additionally trained, that support schools. So it's connecting the NHS with schools and local authorities as well. So we've got a sort of tripartite sort of agreement. Next slide. So what do? They're basically evidence-based interventions in schools. They support a number of schools for mild and moderate mental health issues. They support the sort of senior mental health lead in each school. So they're in the education setting. This is really important. They're not outside the school where where children get taken out of their school environment. They're there to support the school in their whole systems approach. And that it's about helping and supporting what already exists in schools, so enhancing the support systems that they have in each school. So next slide. And this is an incredibly busy slide, but hopefully the busyness is explained by one simple thing. On the left-hand side, this is the team. This is what mental health support teams in schools is actually about in practical terms. We did not create a new organisation which we had to 2P and second lots of staff, because we felt that those legal and organisational barriers would stop us doing something. And we felt integration would come by actually doing something on the ground, that working with people, working with this policy sort of framework, but doing something practical on the ground and not worrying too much about quite complex legal, HR, employment, 2P rules around secondment. So create a team of, on the left-hand side are our clinicians from CAMHS, our local health provider. And then on the right-hand side, we had a range of educational psychologists and CWPs, which are the children's wellbeing practitioners who went on courses and then were integrated in that Ed Psych team. So basically we brought these two teams together to work on a patch of schools, and the clinicians with the red arrows helped support the Ed Psychs and the other workers with clinical supervision, and the Ed Psychs and the children's wellbeing practitioners helped the clinicians with the green arrows around case management and their perspective on the needs of children. And then the two leaders at the top helped with the task management. So they helped allocate people to different, children, young people to different professionals and different groups. So it's a way of just saying, well, we're not going to go through a complicated process here. Let's just bring these teams together and they work together as a team. So next slide. So thinking back about what does this actually tell us about sort of integrated care, that you can have less fragmentation, you can have one team, and you can have a mixed recruitment model and still make a difference to single process and bring people together. You do need to think clearly about that interdisciplinary, and I picked up what Jack said about professional as well, that you need to have organisational comms as the rule, that there isn't separate comms into your own respective organisations, that this team is a new we, that we've developed what we call a team handbook, which is number 4, which sounds quite straightforward and a little bit simplistic, but it actually did work in terms of creating operational rules for how do we manage children. And it started to get us to think about the language that we use and having common definitions about things. So that team were now to had a vehicle to have those interprofessional discussions about what they defined as a referral, for example. I mean, it may seem simple, but actually there's some complexity about what a referral might mean and whether we needed to change our language. So some real sort of practical things as well, that we sort of had some theory about how we might want to do something, but we also try to use a practical way of solving problems together. Number 5, I think, is really important. I'll just make 2 more points for this slide. Number 5 is really important, that it isn't just about health and children's social care, which is often the sort of bilateral conversations that you have, that because we brought, obviously by definition, it's about schools and educational psychologists, it really opened the eyes of health. And I'm from a health background myself, and it was the health team, if I'm honest, that needed to learn, have a steeper learning curve around its interactions with schools. We were the ones who didn't really know much about schools other than our school nursing professionals that we were working with, that health service didn't have a long tradition of working with schools in any sophisticated way. And it was really quite challenging for us. So, for example, we struggled to work out why the local authority weren't running schools anymore. There was a whole history of not knowing what the school's agendas was and the independent nature of schools. And number 6, I think, is, and number 6 and 7 are the same point. Historically, there's been a lot of talk about leadership, and what we found was that we needed to go beyond leadership. Of course, we had some really good leaders and we're really good people that helped us with that journey, but people do move on and people change, and you need to be able to have a set of working arrangements that were better than just an individual's input. And this integration was not delivered by hierarchical instruction. It wasn't something that the council and the NHS locally told us to do. We had a framework around the policy of mental health support in schools, but that was sort of essential, but not sufficient in any way. And it wasn't driven hierarchically, it was actually driven from below and in the middle, was our experience. So my last slide was just, once again, just reflecting, and this links, I think, with a lot of what Jack was saying right at the beginning. There are different ways of looking at integration, and I would really hope people maybe challenge some of their assumptions when they look at their own integration issues, because this is just a case study, doesn't tell you everything. It's a case study of West Sussex, it's a case study of this policy area, but we were trying to get some generics out of this as well, some generalizations, and it is quite difficult, but I think the generics lessons that we could learn about is how we think about integration in a bit more of a systematic way. So there are some conceptual challenges here. I would suggest that you need to keep asking the question about what this integration means. So are we just looking at a geographical or a set of patients or a providers? Are we looking at organizational interaction? You know, we need to look at multiple layers of integration and just keep reflecting on what it means to us. So MS Teams is just one example. Let's also keep reflecting about process and outcomes as well, that it is not as simple as saying it's all about outcomes, it's all about process, that these process and outcomes issues are intrinsically linked, that we never set out to have integration as an outcome in a way. We just set out to do something positive, and we've realized that it's actually better than not working in this integrated way, and we've begun to improve some outcomes that we were really interested in, but it is still early days. But those issues around, is it process and outcome, I think are too polarized. I think they are intrinsically linked here. So we were quite good at asking questions about the how and tailoring it to our local context, but we did need to keep thinking about expected outcomes and measure them better. So we're very early in the day, so we haven't actually got sort of outcomes evaluation yet, and that needs to come in the future. And my last point, I think, is just reflecting on the resources issue. And these are two things really I think people need to think about. One is that the NHS funds was really helpful in kickstarting this process, but it did complement existing resources. It was small fry really in the bigger scheme of things. We're not talking about millions of pounds. We're talking about a few $100,000 in quite a large county of West Sussex. So that's not actually a lot of resource when you think about the 30-40 million that we're spending in this area, and it cannot replace existing whole schools approaches to looking at the well-being of their children and young people, and it doesn't override any whole systems thinking that you need to do. It merely complements it, and it merely acts as a catalyst for thinking about things differently. And my last point is that I would be very wary about thinking that it reduced cost in any very simplistic cash releasing terms. It could be very cost effective, and I think it will turn out to be cost effective, but we're already picking up some of the data around the cost effectiveness and reducing amounts of handovers and wasted staff time on things. But that is cost effectiveness, not reduction of cash. It's not about efficiency savings. I think we just need to think about that like that, and that would help, I think, make your own business case locally about what you actually want to achieve in sort of financial cost terms. So I'm going to leave it on that, and hopefully stimulate some more questions coming up.
Thank you, Aaron, and thank you for all those examples. Really good discussion. So as you'll have seen, and a lot of you participating in the chat in the webinar, so thank you for that. Some of the questions have been answered in that, but I'd just like to go to the panelists to ask a few of the other questions. So there was one that came in about Ofsted, which is obviously always a preoccupation in children's services. The question is that in some cases, Ofsted has unpicked some examples of integration and gone back to binary models. Just perhaps Jack, you could comment on that and what you think of that.
I think that's a really good point, and there certainly have been examples where a kind of preoccupation or a drive for integrating services has distracted from some of the fundamentals that the individual partners need to be focused on. However, I think the increasing numbers of, joint targeted area inspections, for example, for the area SEND reviews, I think are questioning the youth offending service inspections, I think are beginning to question how far advanced we are on collaborative, coordinated working, if not integration.
Thank you. And we've had a couple of questions looking at asking about integration in the health and social care model, particularly the focus on adult social care. So perhaps Deborah, you could give some thoughts on how that is impacting this agenda and how we can encourage children's services and children's services partners to be involved too.
Sorry, John, I think I've lost the thread of that question.
So a question on integration being driven mainly by health and social care and how children's services can get on board with that.
So you're thinking of the wider children's services agenda as opposed to the specifics around those service areas?
Yes, yeah.
I mean, I guess, I mean, certainly, you know, I can't talk for integration in more general, rather than the experience we've had in Stockport. And certainly that's been driven very much from that philosophical perspective of how can we improve things for our children and families? How can we deliver the best possible services? That's incredibly powerful, actually, isn't it? As people who came into public sector, we're very, very keen to do what we can to improve a lot of the residents we serve. So that powerful agenda and that powerful common purpose is a really strong driving force. And certainly in Stockport, we've held on to that agenda really relentless and really rather dogged in that holding on to that principle and that value. And as we move forward, you know, we're having some really, really interesting conversations currently with our colleagues in the CCG around the HIMSS, the CAMS agenda, and how we can align that with our agenda, and also some very healthy conversations about an all-age approach to serving residents right across the health and social care agenda. But it really has to, I think very strongly, I agree with Aaron in terms of savings. Actually, that was one of our imperatives, and we did make some savings. However, that was one of our imperatives, and it needs to be aligned with some other very fundamental and sustainable imperatives around improvement and life chances and opportunities within your local area, that play space. I don't know if that goes. I think Jack's got his hand up.
Jack, did you want to comment? This is probably the last chance we want to.
I just wanted to say that if I've learnt anything about integration, you need to take a whole family approach. And that means working with the adults in those families that are absolutely beset by things like debt or mental health problems and domestic abuse. And I would really signpost people to the Healthier, Wealthier Children programme in Scotland if they really want to look at a way of kind of internally integrating, thinking beyond the very narrow task or range that you're given as an individual practitioner.
And thank you. And I'm afraid we're going to have to leave it there because we've come to the end of our hour. But I just want to say thank you to all the panelists for all the presentations. There's been questions that we can follow up after this webinar, particularly on some of the practicalities of sharing slides and also links to evaluations. But just to say thank you as well for joining us. And please do look on Mutual Ventures website, and you can join next week's webinar on levelling up or keep a track on what we're doing elsewhere. So thank you again, and thank you, panelists.